Just to advise everybody, committee meeting will be recorded, broadcast throughout the building and also online, and anybody in the public gallery can use the Wi-Fi, abide by the rules and take no photographs or record anything at the meeting. Apologies, so we have a few apologies from people who are going to be here slightly late, Nuala being one and Alan being the other and Linda being the third. So, Chair's business, just briefly... What? Okay. Skip that. We'll just move straight to the presentations. Because we haven't quorum to do anything else, so we're going to item number 8. So item number 8 is the oral briefing from palliative care sector representatives on the scoping of specialist palliative care services for children and adults. So can I welcome Trevor McCartney, CEO of the Hospice and the Children's Hospice, Dr. Claire White, Consultant in Palliative Care Medicine, David Graham, Palliative Care Network, and Professor Max Whitten from RQIA. So all four of you are very welcome. We hope we didn't rush you through your coffee. We're going straight to this important session. So thank you very much for sending in your opening remarks. I'm going to hand over to yourselves, just if there's anything additional you want to add to that before we go straight to questions.
We'll just go through the opening statements to begin with then.
Yep.
Chair, Deputy Chair and members, thank you for the opportunity to return to the committee and provide further evidence following your inquiry into accessing the palliative care services. I want to begin by properly thanking the committee for the seriousness, persistence and continued support you've shown throughout this work. This inquiry did so much more than produce another report. It gave patients, families, clinicians and hospices a voice. It kept a long neglected issue firmly in public and political view, and your continued scrutiny now matters more than ever, because the real risk is that acceptance of recommendations is mistaken for the delivery of change. I'm appearing today alongside clinical colleagues who will speak with authority about the clinical evidence, the economic evidence and the human reality of caring for people and families at the end of life. Dr. Claire White will set out the clinical and economic case for specialist palliative care, including the potential impact on hospital deaths, bed days and costs in Northern Ireland. Professor Max Watson will speak to the wider clinical evidence and the human impact in a way I know will be memorable. I will focus on the system issues, funding, commissioning, accountability, implementation, children's hospice care, the hospice role in the future model of care and the practical steps now required. All 27 recommendations from the inquiry are now accepted or partially accepted. That matters. It reflects the strength of the committee's work and is a clear recognition that change is needed. But recognition on paper is not the same as change in practice. That gap between acceptance and delivery is now the central issue. Warm words do not keep beds open. They do not sustain community specialist teams. They do not fund care for children with life-limiting and life-threatening conditions, and they do not provide the sustainable commissioning base that enables hospices to plan reliably for patients and families. Against that backdrop, we do welcome the additional 1.6 million announced for hospices, 1.1 million for adult hospices and 500,000 for the children's hospice. It is important and it should help manage immediate risks to services. We hope that commitment will be honoured quickly in practice and not become caught up in the kind of process delay that has often characterised progress in palliative care. But this is emergency funding in its truest sense. It is one-off, non-recurrent, support provided against the backdrop of chronic underfunding. It buys time, it does not create sustainability. The reason emergency funding was needed is that hospices have long been funded through a comparator that is fundamentally flawed. A general medical bed benchmark is not an appropriate proxy for the actual cost of delivering commissioned specialist palliative care. Specialist palliative care is not simply a bed. It is a consultant-led, multidisciplinary and complex. It includes symptom control, psychosocial and spiritual support, bereavement support, family support, discharge facilitation, community outreach and crisis prevention. That is what hospices are commissioned to provide. A benchmark that does not reflect that reality will always understate the true cost of care. I therefore welcome the Minister's commitment to review the old comparator and for officials to work with the independent hospice sector on a new approach. But that process must be transparent. independently reviewable and grounded in the actual cost of delivery, it must also be linked over time to real inflationary pressures. It should never again be possible for a benchmark affecting the independent hospice sector to be applied without everyone being able to understand how it's calculated, what assumptions sit behind it, and whether it can be audited. During the inquiry, even senior officials struggled to explain how the existing benchmark was calculated. That lack of transparency is deeply worrying. For children's palliative care, the position is even more concerning. Northern Ireland only has one children's hospice. It is a regional service with no alternative provider, yet it's only operating at 6 out of the 10 available beds because of funding constraints. Statutory funding covers only 38% of costs, with the balance dependent on charitable income and philanthropy. Children in Northern Ireland receive fewer nights of care than comparable benchmarks elsewhere in the UK and Ireland, around 5 to 6 nights compared to 12 to 14 anywhere else. A business case for a 7th bed was submitted following engagement with officials, but as yet there's still no outcome from that and still no recurrent funding. The 500,000 emergency allocation for the Children's Hospice is welcome, but it does not answer the central questions. What is the sustainable funding model for Northern Ireland's only children's hospice? Nor does it answer why children here with life-limiting and life-threatening conditions should receive around half the care they would receive elsewhere in the UK or Ireland when 4 empty beds could so easily be commissioned. This isn't just a hospice issue, it's a whole system issue. Claire will set out the economic case in detail, so I will not repeat those figures, but the committee's own report showed the imbalance clearly. In 2022, estimated healthcare expenditure for people in their last year of life was around £350 million. Of that, 56%, approximately £195 million, was spent on emergency admissions. That's £195 million on palliative patients in emergency admissions. Compared with that, hospices only received £14 million, 4% of that amount of money. This is not a balanced system. Too much resources flowing into crisis and too little into prevention, planning and support in the community. Palliative care is not a charitable extra or a soft add-on to the health service. It is an evidence-based intervention that improves outcomes for patients and families and reduces avoidable pressure on acute services. Underfunding palliative care, it's not a saving, it's a false economy. That is why the recommendation for a regional independent clinical lead for palliative care is so important. It should be treated as an immediate priority. A clinical lead is not an administrative nicety. It is the foundation for defining what care is required across Northern Ireland, what good looks like, how generalist and specialist services connect, and how care delivered by trusts in the independent hospice sector works seamlessly around the patient. Without that clinical leadership, we risk continued fragmented planning, inconsistent pathways, and unclear accountability. I also want to address the baseline scoping exercise from the system and data perspective. Claire will speak to the clinical question of what scoping must achieve if it is to improve patient care. My concern is more basic than that. The department's own updates show that the statutory data currently available is not strong enough to carry the weight now being placed upon it. The issue is not simply that the data is untidy. Across the statutory system, patients are not being recognised consistently and defined, coded and recorded as palliative. A GP register may tell us that a practice has a palliative care register, but it doesn't provide the patient profile needed to understand complexity, need, activity or outcomes. District nursing, as great a job as they do, is a core part of palliative care in the community, yet the relevant data is not currently available in a form that allows it to be properly analysed. Even within community specialist palliative care, information is not directly comparable across contracts because the services have been commissioned and therefore report differently. So this is not a small data gap, it's a structural weakness in the evidence base. No matter which statutory data set we look at, trusts, GPs, district nursing, patients are not being effectively and reliably recorded as palliative in the way needed to plan services. So without a significant change in approach, we risk building the next palliative care strategy on data that does not reliably identify who needs palliative care, what they need, what care they currently receive, or where the gaps actually are. Using such a flawed foundation would be a fool's errand. By contrast, the most robust and reliable data appears to sit in the independent hospice sector, because hospices are already recording the patients they serve, the activity they deliver, and the complexity of that care. That data should not sit in the margins of the exercise. It should be central to the Department's understanding of need, cost, and future commissioning. Confidence in Encompass reporting is also limited. In practice, the move to Encompass has made some of the required data less available rather than more available. The risk register for the baseline work is a sea of red. We cannot allow a flawed data exercise to become the next reason for delay. The continuing absence of a current palliative care strategy has been a major weakness. The Living Matters, Dying Matters strategy is over a decade out of date. The committee has recommended a new regional strategy, and that must now be delivered at pace, with the independent hospice sector around that table from the start. We welcome the commitment to establish a dedicated palliative care policy function within the department. That is long overdue. But it must have sufficient authority, resources, and clinical leadership to deliver change, not simply coordinate more and further discussions. In the absence of any completed regional strategy from elsewhere, the Hospice Alliance has commissioned a detailed piece of work setting out how palliative care need could be met across Northern Ireland. We intend to launch that report around Palliative Care Week in September or shortly afterwards. So far, we have received comprehensive political and professional support for the approach. This is not intended to cut across departmental work. It is intended to make a constructive, evidence-based contribution where no alternative regional plan currently exists. We would welcome the committee's support for that work when it's complete, and we intend to share the first drafts with the committee as it develops. Finally, I want to touch on the neighbourhood model. Hospices are already the very definition of neighbourhood care. We deliver care in communities, in people's homes, in hospice beds, and alongside families at their moment of greatest vulnerability. We help avoid inappropriate hospital admission and support earlier discharge. We are exactly the kind of partner the neighbourhood model says it wants, but the funding structures remain unclear. It is not yet clear how the new integrated neighbourhood teams model will secure funding, how that funding will be strategically applied, or how independent providers such as hospices will be commissioned within that model. If hospices are central to neighbourhood care in principle, they must be central to its funding and planning in practice. Chair, in closing, our intention is constructive. We want to work with the Minister, the Department, SPPG, Trust colleagues and the Committee for the benefit of patients and families and for the benefit of the wider health service. We all exist for one purpose and one purpose alone, and that's our patients. But the time for general acceptance has passed. What is now needed is clear delivery, a transparent cost-based funding model, a recurrent solution for all adult and children hospice services, an independent clinical lead appointed urgently, a properly resourced policy unit, and a strategy that turns the committee's recommendations into measurable change. Patients and families do not get a second chance at end-of-life care. The system should not get another chance to delay. Thank you.
Thank you. Yeah, we're okay for questions. Claire, you wanted to say something?
Max was going to speak next.
Okay, Max, sorry. Yep.
Let's go after him.
Okay.
Apologies.
Chair, members of committee, thank you again for this opportunity of coming before you. At first, I would like to acknowledge the 10,000 people who have died since your recommendations were given to the department, and the 2,000 patients and their families who have died in that time without being able to access palliative care. I've been a doctor for 42 years, most of that time in palliative care in this country, around the world, in clinical, academic, teaching, research, publication, and in advocacy work with Hospice UK. I currently hold posts in the Western Trust, clinically, in RQIA with Project ECHO, in Bangalore, in teaching, and in Princess Alice Hospice in Esher. I want to begin, like Trevor, by expressing thanks to the committee for the seriousness, time, and energy which you have engaged with in this work. Your 27 recommendations reflect the evidence you gathered and your clear commitment to try to improve care for some of the most vulnerable people in your constituencies. I also want to acknowledge the tone of engagement that has emerged from recent discussions with the Department of Health in meetings and conversations with the Chief Medical Officer, the Chief Nursing Officer, the Chief Pharmaceutical Officer, Jim Wilkinson, Gerard Cassidy, and other senior officials. There has been welcome willingness to engage, acknowledgement that current services are not sufficient for present or future need, and an expressed desire to work in partnership with providers and the voluntary sector. It's important to recognise genuine goodwill when it is shown. However, Chair, goodwill is not implementation. And for many of us who have spent our professional lives working in palliative care, there is an unavoidable sense of déjà vu. We have heard many, many warm words before. The challenge is not that we lack for warm words. The challenge is that we struggle to see warm words converted into sustained improvement. The Minister's Department's response contains much that is welcome, with so much acceptance of your recommendations. Yet the response stops short of telling us precisely when implementation might happen and what will actually be new. Using software analysis, I find that 60% of the Minister's response was cut and pasted from other departmental documents. And we risk drifting back into the glacial processes in which the department are so invested, processes which are open to being interpreted as procrastination until PERDA falls, a new health minister is appointed, and a new health committee removes the imminent pressure. With fiscal uncertainty, it's easy to understand why this very cautious approach has become the default position. But I do believe both you and the Minister as well want more, and thousands of patients and families need more. They need more action. Your focus today is on Recommendation 6. Within the department response, many of the recommendations are effectively referred back to this baseline scoping exercise. That really concerns me. Not because scoping is unimportant. Robust assessment of need is essential if we are to address inequity and deliver services properly, as Trevor has said. But there is a difference between using evidence to guide action and using evidence gathering to substitute for action. The committee are aware that this scoping exercise has already been subject to repeated delay. Timings have shifted, completion dates have moved, significant questions hang in the air about whether two essential remaining and as yet uncommenced phases of the scoping process can be completed within the available capacity and resource. It has become a Sisyphean cycle of endless processing, which could take so long that by the time it is completed, it will need to be repeated. The scoping also takes no account of Encompass and the terabytes of data that we now have on palliative care delivery across our health system. Data that, with good management, could provide a real-time assessment and dashboard of what is currently really happening in palliative care in the acute sector at the moment. This would give us the opportunity to monitor change and monitor improvement in real time. We need the leadership and courage to move from asking what the problem is to deciding what we are going to do about it, based on good enough evidence rather than waiting for the perfect evidence. While we continue to scope, review, and consult, the demographic reality continues to rapidly change, but care delivery falls ever further behind. Demand is not waiting for the completion of another scoping exercise. It is already here. The most important development since this committee submitted its recommendation is scientific. The economic modelling for palliative care has been changed by a body of work recently published, as Claire will highlight to you. The evidence now demonstrates that palliative care improves outcomes for patients while simultaneously reducing costs across the whole system. Is the committee aware of any other economically viable intervention that has the proven evidence of reducing the number of ambulances waiting outside our A&E departments and the pressure on our acute hospital beds? The evidence is there. I want to be optimistic. We can achieve much and most through collaboration and building working relationships that deliver real change for patients and their families. Chair, I would also like to ask the committee to think beyond this mandate. I speak here from personal experience. When I began this palliative advocacy work, I had a full head of hair. The greatest risk facing us is frustration and exhaustion and giving up because it's such a slow process. The risk is that recommendations are accepted but not funded, timelines are extended, elections intervene, priorities change, attention moves elsewhere. Before the end of this month, your focus will rightly pivot to Muckamore and urology. But the care of thousands of people approaching the end of life will still need to be sustainably improved. Having spent many sleepless, disturbed nights since the publication of the department's report, I would seek the committee's indulgence to finish with a poem which captures those long hours of angst. It's called Ode to a Minister's Legacy. Chair, members of the committee, thank you. Thank you for your work of attentive listening, your growth of insightful understanding, your cross-party focus, your refusal to let this matter drift into yet one more report and 2-minute package from Marie-Louise. You gave us all 27 recommendations, not 27 complaints, but 27 opportunities to ensure better care, again, for us all. And now we have the response, and there is much to welcome. Warm words, affirmations of new collaborative intent, most of your homework marked correct, though sadly impossible to deliver soon because of financial constraints. And then, rabbit-like, or from somewhere down the sofa, suddenly 1.6 million ministerial reasons to be grateful. And the hospices are truly grateful, though both cynicism and hope compete to respond wholeheartedly. For we who have travelled a lifetime in palliative care have learned to recognise a familiar pattern. A scoping exercise follows a review. A review follows a consultation. A consultation follows a preliminary discussion. A preliminary discussion follows a scoping exercise. And somewhere between the meetings and the minutes, time passes. Patients pass. Families pass through dying unmitigated by palliative care. The need does not pass. The population grows older, demand grows greater. While the evidence is now clear, a full 3-month dose of palliative care improves lives, reduces hospital admissions, saves bed days, helps sustain the health service itself by saving thousands and thousands of pounds for each patient. Palliative care is not the sweet, shiny cherry on top of the NHS cake. It is in the very flour. Without it, the neighbourhood model cake will remain unbaked. Without it, the most powerful incentive for co-creating vital whole system change will be squandered. So it is not more warm words or statements of gratitude or hope for promises or visits to our hospices that patients and families most require. All of us need or will need much more. Rather, 3 words to build trust for meaningful collaboration that truly delivers. When? When will this work be completed? When will you report back? Who? Who exactly is responsible for delivering? Who will report back to the committee? What? What exactly is that honest commitment? Not eventually, not in principle, not subject to a culture of obfuscation hidden deep within endless process. Because accountability to us all becomes meaningful only when these questions are answered in truth and in time. And finally, a request to this committee. Please do not let this be the end. Whatever the next assembly looks like, whatever minister occupies the office, whatever priorities compete for your attention, please keep the care of our dying as the canary revealing the true care being delivered by our health service. Do not allow your hard work begun to disappear into purdah, into transition, into the long, long grass of procedure. Resist the temptation to give up in frustration. Our dying need your persistence, as do those who care for them in hospitals, in care homes, in hospitals, in homes big and small. They also need to know, as each one of us in this room need to know, as our colleagues in castle buildings need to know, as the minister needs to know, that when the final chapter comes, good care has not been left to chance. Thank you.
Claire?
Good afternoon, Chair, Deputy Chair and members. Thank you for inviting me back to speak to the committee. I'm a consultant in palliative medicine, working between the Northern Ireland Hospice and the Mater Hospital since 2010, and I've worked in palliative care since 2004. I want to begin by thanking the committee for its report on access to palliative care services and for the work, time and attention that went into it. Those of us working in palliative care felt genuinely listened to. We felt the committee understood what we do, why it matters, and why the current arrangements are not good enough for our patients and their families. The report was thoughtful, practical, and, if implemented, would significantly improve palliative and end-of-life care across Northern Ireland. We welcome the fact that the Minister has accepted many of the recommendations and the recent one-off £1.6 million emergency funding for hospices. But we remain deeply concerned that there is not yet the recurrent funding, delivery plan or implementation structure needed to turn the committee's report into real change for our patients. Palliative care must be seen as a core part of the NHS. We are told that the NHS is cradle to the grave, yet it often excludes the grave. Palliative care can no longer be treated as something sustained by coffee mornings, fun runs, and the generosity of our local people. Charitable support is important, but it should not be the foundation on which essential healthcare depends. In my 22 years working in palliative care, I've seen services develop organically and opportunistically, often because committed clinicians saw a need and tried to meet it. That dedication has achieved a great deal, but is not a substitute for strategic planning. Without proper oversight, services have grown unevenly. Provision is not balanced. Access is not equitable, and funding has too often been ad hoc. The investment in and expansion of palliative care services has also lagged behind other medical specialties that have benefited from clear strategic plans and funded implementation. For example, oncology services in Northern Ireland have seen major investment, including the North West Cancer Centre, growth in specialist staffing and training, and a comprehensive cancer strategy. That investment is essential and should be welcomed, but the question remains, why has palliative care not had the same strategic priority when it supports patients with advanced illness across every trust area? The moral case for palliative care is clear. It has been for many years. To care for some of the most vulnerable in our society, reducing suffering and allowing people to die peacefully and with comfort and dignity. But the economic case is now much clearer as well due to recent evidence. Although less than 1% of people die annually, in Northern Ireland, people in the last year of life account for an estimated 10 to 30% of all health and social care resources, much of it driven by acute hospital admissions. Yet we know that most people with serious illness would prefer to be at home if the right support is available. Yet many still attend hospital repeatedly in the last months of life, and hospital remains the most common place of death in Northern Ireland. Cochrane Review, another meta-analysed trial evidence, has found that both home and hospital-based specialist palliative care increases the odds of dying in your own home and improves quality of life. But until now, we've had no evidence of whether or not this was cost-effective. Since the committee published its report, we now have this evidence. Recent health economic modelling in England shows that specialist palliative care improves outcomes for patients while simultaneously reducing costs across the wider healthcare system. Access to home-based specialist palliative care was associated with reduced costs of about £7,908 per person who dies, while still improving their quality of life. Access to hospital-based specialist palliative care also reduced costs, this time by around £6,480 per person who dies, while also improving quality of life. The increased costs associated with being at home were more than offset by the money saved by reduced time in hospital. The same modelling estimated that in England, specialist palliative care currently supports more than 20,000 people each year to die outside of hospital, saves approximately 1.5 million hospital bed days, and reduces health system expenditure by approximately £817 million annually. This evidence is directly relatable to us in Northern Ireland. Our structures for home and hospital-based specialist palliative care are comparable enough to allow us to estimate the scale of the potential benefit here. While there are limitations to the study, extrapolating the data in Northern Ireland using our population size of 1.93 million as a basis finds that, firstly, access to home-based palliative care should lead to 579 fewer deaths in hospital, 33,860 fewer hospital bed days, with the lowering of NHS costs by approximately £18 million per annum. Secondly, access to hospital-based palliative care should lead to 132 fewer deaths in hospital, 16,645 fewer hospital bed days, with the lowering of NHS costs by approximately £9.6 million per annum. If these two figures are combined, this gives Northern Ireland a total estimate of 711 fewer deaths in hospital per year, over 50,000 fewer bed days utilised, and a potential saving of over £27 million, just by funding specialist palliative care appropriately at home and in hospital. To put that in context, 50,000 bed days is 137 beds not being occupied each day, the approximate equivalent of the entire Mater hospital capacity. That is not a marginal issue. This is system-level capacity from investing in specialist palliative care in hospitals and in community. And all this even before we fully account for the impact of specialist inpatient hospice beds, which care for the most complex palliative care patients. These are people who otherwise may be at home with uncontrolled symptoms or in emergency departments and acute wards for prolonged periods of time because the right specialist support is not available. Specialist hospice beds improve quality of life, manage complex symptoms, support families, and help people live as well as possible until they die. Hospice services across Northern Ireland already provide extensive care. In 24-25, hospices delivered approximately 43,000 specialist nurse and doctor home visits, 14,000 outpatient appointments, and 19,000 inpatient bed days. These services are not peripheral. They are already helping to prevent avoidable hospital attendance, support earlier discharge, manage complex symptoms, and provide care that the wider system would otherwise struggle to deliver. Further health economic modelling is needed to clarify the impact of specialist inpatient beds, as this was not included in the aforementioned study. We also need to recognise the scale of unmet need. Estimates suggest that around 11,300 people in Northern Ireland who die each year have palliative care needs, but around 3,000 of them do not access palliative care services. This means roughly 1/4 of those who would benefit from palliative care at the end of life are not receiving it. Ensuring these people are identified and get access to palliative care when they need it will result in better care, as well as using healthcare resources more effectively. So how does specialist palliative care save money? It does so by supporting people earlier, managing symptoms better, preventing avoidable crisis attendance at the emergency departments, reducing unnecessary hospital and care home admissions, supporting faster discharges, and helping patients and their families make informed decisions about what care is appropriate and where that care should happen. In hospitals, specialist palliative care helps teams recognise when illness is advanced, avoid burdensome investigations or treatments that will not benefit the patient, manage distressing symptoms, and support discharge planning. In the community, specialist palliative care helps people remain at home when that is their wish, gives families confidence, and provides rapid clinical support when needs change. There are practical models already in Northern Ireland showing what could be done. The Belfast Palliative Care Hub responds rapidly to changing patient need and can help avoid crisis hospital attendances by same-day intervention at home by a specialist nurse or consultant. Specialist palliative care input into emergency departments, such as the model in Antrim area, can help people return home as quickly where possible, and when admission cannot be avoided, can expedite symptom control and reduce length of stay, hence saving money. Expanding services from 5 days to 7 days and ultimately ensuring 24/7 support would make a major difference to patients, family and the wider system. Palliative care should be understood not only as compassionate care but as excellent value care. Indeed, it is one of the most credible ways to support the neighbourhood model, moving care closer to home. Coming briefly to recommendation 6, as it's already been covered in more detail by Trevor, we do need to know what services are available, how they are funded, and what is needed based on Northern Ireland demographics and patient preferences. But to make any scoping exercise relevant, it must have an outcome. This current scoping exercise has just demonstrated how much palliative care has been neglected over decades as it cannot access reliable data and is just a narrow lens snapshot at one point in time. If not matched to population need, it is very limited in its relevance to developing services. Patient and service needs cannot just be based on extrapolated population data. It is much more nuanced than that. In hospitals, a cancer centre will likely have a much higher level of specialist palliative care input needed than a district general hospital. In the community, geographical distance is important to determine the ability of specialist nurses to visit patients in their own homes or for less well patients to travel to clinics. Older people with hearing and visual impairments are likely to take more time than those without communication barriers. There are many variables that scoping must consider to make it of value for developing services that meet patient need. Over the years, clinicians and managers have invested huge time in working groups, reviews and reports in the hope that they would improve patient care. Too often these documents have not led to meaningful implementation. That is demoralising for people involved, but more importantly, it's a missed opportunity for patients and their families. The committee's inquiry has created a real opportunity. The department's response, the emergency funding, and the new economic evidence all point in the same direction. Palliative care must now move from the margins to the centre of healthcare planning. My ask of the committee is therefore simple. Please keep pressing for the recommendations to be funded, implemented and measured. Please ensure that specialist palliative care is treated as a core part of the health service, not a charitable extra. And please keep asking the practical questions. What will be delivered? Who is responsible? When will it happen? And how will patients and families know that care has improved? We have a chance to improve care for patients and families across Northern Ireland while also reducing pressure in hospitals and supporting the wider health service. The moral case is clear. The clinical case is clear. The economic case is now clear as well. Thank you.
Thank you very much, all of you. That was very impassioned and very, very useful. I think it's the first time in my role as chair I've had a poem read. English literature wasn't my greatest subject at school, but I think my old teacher would have been very, very impressed. So thank you all. I just want to start my contribution by just assuring you, because...
Do you mind if I say a few words?
Apologies, sorry, I thought we were finished.
I won't be long. Thank you. And thanks for the invitation to come along. Chair, members of the committee, thank you for the opportunity to give an update this afternoon. I thank you for your report with its recommendations. So I'm David Graham. I'm here as the lead for Paediatric Palliative Care Network, and also for someone who works week in, week out, day after day with children and families who have children, young people with life-limiting conditions, palliative care needs in Northern Ireland. So your report on access to palliative care sets out a credible, evidence-based roadmap for change. And for children and young people, it's not a nice to have. It's a difference between a system that supports families to live as well as possible, and one that leaves them, and not one that leaves them navigating crisis alone. My concern is that if your recommendations are not fully implemented, the gaps you've exposed will become more entrenched and not reduced. First, the issue in relation to place of care and place of death. Families repeatedly told your inquiry that they wanted their child to be cared for, and when the time comes to die, in the location of their choice, usually at home or in children's hospice. Yet because of limited 24/7 community nursing, patchy out of hours medical support and constrained hospice capacity, too many children still receive end of life in settings that not what they wished for and less than ideal at times. I'd like to draw your attention to the Built to Last report, Together for Short Lives, released last year, showing that in Northern Ireland only one health and social care trust even partially meets the 24/7 end of life care at home for children standards. And families effectively face a postcode lottery in access to specialist support. So if your recommendations on community services, hospice funding and regional standards are not delivered, we'll continue to see children spend their last days not in the place of their choice, and it could potentially lead to families carrying preventable trauma into bereavement. Secondly, in relation to the specialist palliative care workforce, children's palliative care is not simply an adult palliative care scaled down. It requires specialist skills in symptom control for complex conditions, communication with children at different developmental stages, and supporting parents and siblings through very long illness trajectories. Across the UK, Built to Last report that I mentioned describes significant workforce shortages and an urgent need to expand training posts in paediatric palliative medicine and community children's nursing. And it warns of a workforce in crisis. In Northern Ireland, we do have a small number of exceptionally committed clinicians and nurses that are thinly spread. There is, at the present time, no fully developed tertiary level consultant post in paediatric palliative care to provide leadership and complex case support and regional coordination. Without implementing your recommendations on an all-age palliative care clinical lead and on building specialist teams, we will not be able to recruit, train and retain the workforce that children and families need. Developing and properly resourcing a tertiary level paediatric palliative care consultant role linked into the regional network into Children's Hospice would be a tangible step towards changing that reality. I haven't mentioned there, but I would like to also welcome the acceptance of the regional palliative care lead, but I would also like to emphasise that it's very important that children's and young people's care isn't diluted in that role amongst the adult world. Thirdly, in relation to funding and sustainability, Trevor's already covered the hospice funding issue, but the department's recent one-off allocation of 500k to the Children's Hospice is welcome, but without the non-recurrent funding that you recommended, it won't allow services to plan, to staff safely, or to expand respite and outreach and other potential services. If your proposals for a staged move to full sustainable funding are not followed through, we risk bed closures, reduced respite and the loss of highly skilled staff to other parts of the system potentially. I'd like to mention transition. It's a critical pressure point, and it's a problem that's become more evident in Northern Ireland. There are reports that show that. Together for Short Lives Transition Pathway sets out the need for multi-agency planning well before transfer, involving health, social care, education and hospice services, so that young people move into adult care with continuity rather than falling off cliff edges. Research on transition in paediatric palliative care stresses that poorly managed transition is associated with gaps in care, emergency admissions and distress for young people and families. Your recommendation for a regional framework and commissioning model that covers young people as they move into adult services is therefore not an optional extra. It's essential to prevent avoidable crises at the point when families are already under enormous strain. I would like to touch on the important legislation question. The department has argued that the existing general duty to commission health and social care is sufficient for palliative care and that no specific legislation is needed. International experience suggests otherwise. For example, in Canada, they passed their framework on palliative care in 2017. That framework made training, data and equitable access explicit national priorities. And their government's 2023 progress report shows that since then, more Canadians are receiving palliative care, more are dying at home with support, and hospice capacity has grown. So the lesson from Canada isn't one thing that solves everything. It doesn't. They still do have some gaps, but having that legislation has created a clearer national direction, a duty to report publicly on progress, and a platform for investment in training, data, and community-based care. For a small jurisdiction like Northern Ireland, targeted palliative care legislation, as your report envisages, could do the same, turning warm words into enforceable duties, especially for children and young people whose needs can otherwise be sidelined. And finally, I want to emphasise that implementing your recommendations is simply not about avoiding harm. It's about building a system that's generally built to last for children. Specialist paediatric palliative care led by a tertiary level consultant and a stable multidisciplinary workforce backed by sustainable hospice funding, 24/7 community support, transition planning and clear statutory duties will allow more children to live as well as possible for as long as possible, and when the time comes, to receive care and die in the location of their choice with dignity and support. If we fail to implement what you've set out, we'll continue to ask families to carry an intolerable share of the burden. We'll continue to spend scarce resources on avoidable emergency care rather than on planned, community-based and hospice care that we know works. I would urge the committee to maintain strong scrutiny of the department's response, to press for a clear, costed implementation plan with timelines, and to keep children and young people at the forefront of that discussion. Thank you.
Okay, thank you very much. So just again, in terms of trying to give some assurance, I mean, when we took evidence exhaustively through our inquiry process, we said that we hoped that our inquiry report wouldn't let you down. And just to give you that assurance, now that we have got our inquiry, we don't intend to let that rest until it's implemented. we will do whatever we can. I mean, I'll give the commitment as chair of this committee that in the remainder of this mandate, our inquiry report will be extremely high up the agenda. At the end of this mandate, each committee sets out a legacy report to hand over to the next committee. I can assure you that this issue will be handed over to whoever MLAs are elected and whoever is in the next committee to hopefully take forward to ensure that. So that will be the committee's legacy. I know your poem was about legacy for the Minister. I share all of your concerns. When we last took evidence from departmental officials, I got the sense that it seemed to me that here was an issue that within the department they intended to long finger, your words, procrastinate and delay until after an election. And I hope that when we took that evidence, we gave the impression to the department that we won't accept that, and we won't accept that. Your visit here today is evidence that we won't accept that. It's not for a Sinn Féin MLA to give a UUP minister advice, although the EU probably needs somebody giving them advice at this particular minute in time. But I do believe, and I've always believed, that this was a legacy issue for the health minister who wasn't standing again, and I would send that message through this committee today that this issue has cross-party support. There will be nobody from any political party that will argue with our health minister if he elevates and promotes what this committee gave to him in terms of our 27 recommendations. He will have the full support of this committee and the political parties contained within it, and I think that would be a very good legacy for any health minister, over and above the fact that it's just the right thing to do. So, I mean, we've heard stark evidence today, we've heard that evidence over the period of the inquiry. The clinical evidence is clear, the economic evidence is clear, and yet we see services remaining underfunded and inconsistent. And I totally agree with you that, you know, we no longer need to recognise the problem. We know the problem, we've identified the problem, we've identified solutions. What we actually need to see is delivery. So my role and the role of this committee is actually to scrutinise evidence, to interrogate evidence, to ask questions. From my point of view, we've done that during the inquiry. I don't tend to ask you any difficult questions today, but I do just very briefly want just a couple of things that I believe are important, because palliative care is, in my view, a crucial aspect of our healthcare for people at their most vulnerable time. And as you have outlined, you know, we're currently fundraising to provide that, and I don't think that's an unacceptable. It would be useful just to set out in simple terms for maybe the people listening, you know, the kind of services that are in danger if there isn't recurrent funding, and then the kind of services that you can do and provide for people. I mean, to be honest with you, I was kind of taken aback, because sometimes you do need to hear these figures. You know, 2,000 people have died, max, without receiving palliative care since we have produced our inquiry report. I mean, that's shocking, to be honest with you. I mean, that kind of did shock me. So, you know, I think we need to get action before another 2,000 people are dying without palliative care. So in terms of the funding, I mean, we're clear that we believe the department aren't funding palliative care and hospices to the extent. So just briefly, what services could you do with more funding, and what services that you currently provide could be in danger if there isn't recurrent funding?
If you look at what the overall aim of the strategy we're working on is, it's to have and hold the patient. So being able to keep that patient 24/7, 365, and having the kind of services that can hold on to them. At the minute, we can't do that because in some cases services are 9 to 5, 5 days a week. We want to have out-of-hours services. We want to be able to care for the patients out of hours. We want to develop the community services. But if it requires charitable funding to do that, the simple fact is this: there's not enough of that out there. It isn't going to be the case that we will be able to do that by charitable fundraising. We will need a cohesive strategy and plan that's backed with appropriate funding to be able to do that. And as both Max and Claire have called out, one of the single biggest issues in terms of unmet need, it's not known to us sometimes. That's a reality. The infrastructure and the systems do not look at those patient journeys to try and understand where are these patients, who are these patients, how do we access them, and how do we care for them. And I think the biggest frustration that we all see is there's so much that can be done that an average health economist looking at it would see the counterfactual, which is if those services are not delivered, it is a statement of the obvious that it will fall back into acute services where the patient will not receive the care they need, and the acute service will be blocked and the flow through the acute services will be impeded.
Can I add just one thing to that? And that is, again, just putting the patient right in the centre. Adequate palliative care across our system would allow us to ask the key questions. What would you want in the event of coming to the end of life? So we do not end up with people defaulting into accident and emergency departments or receiving care that they wouldn't want. So palliative care allows us to be a lot more patient-centred, and by being patient-centred, to relieve both the system, but also to relieve the distress of families who witness people dying inappropriately in the wrong places at the wrong time with the wrong care.
Not to steal Diane's thunder, but she's often compared one service with the maternity service. Imagine 2,000 children being born without appropriate care. I think that would be totally unacceptable. So just with regard to children's services then, and the children's hospice, there's currently 6 out of the 10 beds operating. So just explain to us what that actually means for families, and if there are children out there who could be getting care that currently aren't because of that funding issue.
And that is exactly the case. It is an equity issue. Northern Ireland is the only one of the UK regions or all Ireland where you will only get 5 or 6 nights care. Anywhere else, you'll get 12 to 14 nights. And that is what is expected. That is what is supposed to be delivered. But when you're only operating 6 beds for 300 to 400 families who absolutely need that, you're never going to be able to meet that. And that has real consequences for families and children from further away. Once upon a time we had what we called the 1 hour plus bed. So children from Fermanagh further away, they were prioritised going into that bed. That was closed by the department. So what that means is less provision, and you end up in situations where when a family arrives, by the time they've decamped into the service, it's nearly time for them to go again because they've only got a few days and they like to spread them out through the year. That is not an acceptable position. There was a study done which actually clearly called out that every £1 invested in children's hospice service generated £6.43 in economic benefit, simply because those families tend to become healthier, more economically active. There was less time lost at work. It was a statement of the obvious, but that seems to have been largely lost. But we in the children's hospice have 4 beds that we could stand up very quickly that would absolutely meet that need, and we even have the potential for foreign direct investment that could help support that. But because government won't and haven't stepped up, that is why we're in the situation that we're in. And the single biggest frustration I have is we have had so many false starts. We have had debate after debate, which was by the end of March we were supposed to have had a benchmarking study completed by the department, which would then have allowed us to confirm that we were actually value for money, and that would be the basis for opening potentially the remaining 4 beds. Well, we were told that benchmarking piece hadn't been done, but then we were summoned to a meeting in the department and shown that it had been done. And what it actually showed was that we were very good value for money. We knew that anyway, but again, it's one of those situations where as the can gets kicked down the road, families are still waiting to get into the service and progress is not made. And that's why in my opening statement, the point I'm making is we need to stop this. We need to make sure that this moves from lots and lots of talking, activity with the illusion of progress, into something which is, here's something we're going to do, this is the difference it's going to make to families, and do it in a way that's actually quite easy. Money invested in hospices can be turned around into a service very, very quickly.
Okay, thank you. And I was just checking then when the department are back again. So they're back on the 3rd of July, so if they're listening into this, they need to be coming prepared to answer the questions that we have in relation to that. Dan?
Thank you, Chair, and thank you for the presentation. I think we're all frustrated. I think the department do many things well, but they do process exceptionally well. And we're really afraid that process, like you, that process will take over and that we'll not see outcomes. And that is a big problem. Chair's right, I often describe this, that we would never ever in this country allow the birth of children without a plan, for planning for that. But we allow people to die without adequate plans. And I think that is an appalling situation for us to be in. David, you mentioned legislation. So one of the things that I had looked at was the amendment that Baroness Finlay brought about in England, which seemed to me to make hospice and palliative care a core part of the NHS. Is that what you're talking about? Is that what's necessary, or is it wider, deeper?
Well, I wouldn't be an expert in the area, but I would say that the examples I've heard, for example, that Canadian model, when speaking to the consultant that led the charge for that, or the campaign for that, it very much made major changes to the paediatric palliative care model, and it drove things forward much more, held people accountable much more. So that's I'm not sure the exact nature of the England model. Maybe Max, you know more about that.
I worked a little bit with Elora on that, and we had such high hopes for it when it was passed, because we thought that would be compulsory then for...
lead to commissioning.
For commissioning.
Yeah.
And then it seemed that commissioners were able to fudge it by saying, oh, we're doing palliative care, we support our GPs, well, we support our district nurses. So the actual benefit that it's been has been really watered down.
It's disappointing.
It has been very disappointing. A lot of work went into that, for exactly the reasons that you raised, and that Elora is well known for, highlighting the inequity of having a service for people at the end of life out of sync with other times in people's lives.
Okay. Can I just ask a couple of questions then that are a bit more specific? So the department has said that it will start the process of a clinical lead for palliative care. What's your understanding of the timeline of that process, and how long do you think it should take versus how long the department think it should take, and how can we actually use our influence, and particularly when they're coming here on the 3rd of July, to say to them, you know, like we want this done. This can be the start of your delivery. It's not it's the least expensive bit of it, but it could lead to change. So maybe you want to elaborate on that?
The latest conversations I've had with the department were timelines that went into 6 months to a year, and the reality is that's unreasonable. You can recruit into a post like that 2 to 3 months. I asked what the delay was. They mentioned they were reviewing job descriptions for that. There are plenty of job descriptions from across the UK and Ireland for exactly that role. This is the role which, when operated effectively, will tell us what good looks like and how we can best develop the services to have and hold those patients again. Without it, that becomes very, very difficult. And if the department is setting up a new unit to look after palliative care, which is good, to not have a clinical lead sitting in the middle of that from day one is tantamount to ridiculous. So I think that is something the pressure should be applied to very quickly.
If the department wanted a job interview, a job description, could have one here in an hour from England, Scotland or Wales, who also have clinical leads. It's the same. It's not a full-time job. It's probably 2 PAs.
Okay, so reviewing a job description really could mean anything, and I just, if there's something that can be delivered very quickly, that seems to me one of the things that can be delivered, and there's no reason why they can't get on ahead and do it, and that's maybe something for us actually to take up. The scoping exercise. Now, I know I go on a bit about the scoping exercise, but This scoping exercise seemed to me to be announced to the committee. I don't even know when it was announced, about a year ago, more than a year ago. And it's kind of like, sort of, let's get something at the committee that we can talk about. And that might be harsh, but I do believe that's the kind of value was put on it. Now you're saying, and I've actually written it down, that the scoping exercise cannot be delivered. Now, we had a lot of warm words about it being delivered, and that the part one of that scoping exercise as to basically what's out there in terms of palliative care would be delivered and be ready for us within a matter of weeks. June. Well, we're in June. Yes, we're in June. So, but you're saying, I actually wrote it down, that there is such a structural weakness in the evidence base that you cannot deliver the scoping exercise. So why on earth are departmental officials wasting their time and our time talking about a scoping exercise which you say there is no data for?
And when you look at the latest developments in there was a piece of work being done by the department with the trust to confirm once and for all that the data was not available in the systems, and that has just come back now saying no, it is not available in the systems. So no matter what way you look at it, that is not something which is going to gather the data as defined. So what we've asked, so I sit on the project board for that, Liz Cuddy, CEO of Evora, is the co-chair of that. So we have acknowledged now there needs to be a reset. So we need to pause that and look for the department to produce something which will deliver an outcome that we can use going forward, because this is not it. You're in a situation, there's three aims. Aim one is to understand the services out there and who uses them. Aim 2 is to identify the population need that would dovetail into that, and aim 3 is to get the service user feedback coming back from that. If you look at the risk register, it clearly says that because aim 1 is essentially fatally flawed, aims 2 and 3 can't progress. If you take those three aims together, they're exactly what is needed to start a strategy. So bring that full circle. If you do not have any of that, you can't develop a strategy, it will go into delay, and that's not something we can afford to have happen. So we need an alternative. And what I do want to make clear is that we want to work constructively with the department to produce something, and we think there are probably ways that we can do that, which is why we're developing a strategy ourselves. But sometimes you need to just call it and say it's not going to work that way, let's find another way.
So just to be clear, and before the officials come back, has the department now called it and said, we do not have the data to actually finish this. We don't know actually what's out there because we haven't recorded it ever, or we haven't recorded it in a way that is usable for the purposes that we want it. Yes. Have they called time on that? Is that, can we take that as read? They're not going to come back and tell us anymore.
What they have agreed to do is to produce a report to confirm those findings and bring those back.
Okay, I mean, this fascinates me. We have spent a year and a half being told nonsense.
Yep.
About a process that the department are paying millions of pounds into. Should be doing much more, but they're paying millions of pounds into, and that, you know, people who love the hospice movement, and it is one of the great movements of our time, are really supporting as well. But actually the department can't tell us what they're getting or doing for the money that they spend. Is that the nub of it?
If you were looking for an output at this stage, you do not have one. If you were looking for a way forward to produce an output, you don't have that either. So what we need to do is essentially reset that. But it's not that this couldn't be done. It could. Max will know ways you could potentially achieve things like that. A clinical lead in place would actually have ideas as to how potentially you could do it. But that was absent.
If we keep on doing this, are we going to waste more time?
Of course.
And more process.
More process.
And more talks and more meetings.
Yes.
the scoping seemed to have 3 legs, one leg which is to be delivered in June, and 2 other legs which the Public Health Agency said they couldn't deliver on when they were speaking to you last day. So it seems to have been a flawed process. But why not turn it on its head? And why don't we look at where we do have data? And we haven't had data before. Now we've got gigabytes of data in Encompass. Mm-hmm. Why don't we develop the tools to allow us to interrogate that data, to provide a snapshot of what is happening in palliative care terms across our hospitals, our accident and emergency departments, our ambulance services? I appreciate it's not the whole system, but it would give us some concrete data, and then if we implement change, we can see, does it decrease the number of people who are coming into casualty in the last hours or days of life? We've got data now. Can we get the skills? And I think, Danny, you talked about health economists. We need a health economist's view of this. While we are just latched into 1 year or one cycle, we miss the potential that there is here to actually make strategic change to the whole system by addressing palliative care need.
Can I just ask one more question, Chair, and I promise I'll move on. It's really it's about funding for the hospice. So 1.6 million, and that's only to sort of plug a hole, really. And keep you there. I mean, the last time we talked, Trevor, you were talking something like about 25%, 30% of funding for palliative care comes from the department, and the rest is delivered through various fundraising activities. So I think that's a ratio, I don't know, 10, 12 million versus the rest, 30 odd million.
Yeah, there's about 13 million.
My maths isn't the best.
In total, but the hospice sector is worth about 40 million. So the vast majority of it comes from fundraising, philanthropy, commercial activities like shops, multiple other things.
And you're saying that is still not enough. We are saying that the department should move towards that 50% at least of funding, and then ultimately traverse the journey to making this an sort of an inescapable funding within the National Health Service, while that fundraising will provide enormous amounts of extra relief for people in the most vulnerable times of their lives. So, given that 1.6 million is just a stopgap, and given that trusts have to provide at least 2% to a neighbourhood model of working, what conversations are ongoing to at least tap into some of that funding for hospices who already work, or the wider palliative care movement who already work significantly within the community? Because I've forgotten the ratio of hospital or patients to community patients. I've forgotten the figures around that.
Most of the care we provide is actually out in the community,
Yeah.
so we'll look after about 30,000 patients as a sector a year, but the vast majority of those visits will be out in the community.
What conversations are there ongoing around that? I mean, I do understand that if this isn't a magic 2% and it isn't the barrel of oil that doesn't run dry.
So the Permanent Secretary, when he was here last, talked about how that would be implemented, and he had a 3-year plan. Mm-hmm. So 50 million 1 year, 100 million, and then 150 million. And Danny very rightly asked the question, which was how are hospices being included and how that will operate. So that will operate it through the new integrated neighbourhood teams that are being set up, and there's I think 20 something of those being set up. But they have not yet defined how they will operate, how they will access that funding, and how that funding will be deployed. So that is one of the fundamental issues. And what we would hope is that funding would then help with the trajectory which the committee has called out, which is 50% right now on an appropriate benchmark. not what it is at this point in time,
Yeah.
and then 10% incremental each year up to 100%. But I do not think that those INTs, integrated neighbourhood teams, as they're set up at the minute, will have the resources, the authority, the governance structures, the decision-making structures around that, because we haven't seen that yet, and that is the challenge. It's one of those situations again where the idea is sound, the principle is sound, the execution isn't there yet.
I was really worried at the committee meeting when one of the department that you questioned wasn't able to tell you what the cost of a bed in Antrim Area Hospital was.
Yes.
And if you're not able to tell what the cost of an Antrim Area Hospital bed is, how can you work out what 2% is? Or how can you work out what it's a blancmange of uncertainty, and where the commitment, and it will take a huge commitment to move from acute sector into the neighbourhood model. You need better than that.
Yeah. So just before we move on to the next, just to let everybody know, because we have another very important presentation, we've got the 4:45, and then we're going on to the next presentation. So the next one then is Linda.
Most of my questions are probably for the departmental officials from the presentations and from the conversation, to be honest with you. But I suppose just in terms of following on from your last answer, so even if you were able, even if there was a good process for that 2% in the trusts, much of the hospice delivery is not trust specific. So it's right across the north, and I'm thinking specifically the children's, but also other multiple different areas in hospice provision in the home, and all of that is not trust specific. So that adds another layer of complication if that's going to be done through the trust for yourselves. Are they going to say, well, we'll only fund you for the people from our trust? And how do you, that is just an administrative nightmare for you to have to start trying to draw down that funding and trying to account for every penny. Already under pressure, and now we have to, in order to get money, we have to hire further people to do administration to account for how we get that money. Am I right in saying that?
Yeah, you are. And this is what the committee called out very early on, even before this was an issue, which was there are a myriad of contracts that hospices manage from a myriad of trusts, SPPG and others, for a myriad of different services. And we have to be very slick in terms of how we operate those to make sure we comply with many and varying different terms of service. But this is actually a step even beyond that, because depending on how it works out, we don't know, it's not clear. Well, if you have more than 20 INTs and they become a way to commission services or define services, then does that mean that contract landscape could get even worse? It just gets very, very complicated. Now, there are some trusts that are really excellent at this. So, for example, the Northern Trust is a really good example of how they work well with hospice services in terms of ensuring that they pay 50%, ensuring that it's volume related. The more you do based on need, the more you'll get paid for that. And the contracts are multi-year funding contracts, but they're unique. There is inconsistency in terms of delivery, and I don't see anything changing that anytime soon.
I agree with you, they are unique in terms of the hospice stuff, and unfortunately, because this is not done from a departmental level, that means other areas lose out. So I worked with two families. Unfortunately, one of them lost their child this week. You were taking care of that child, and the one thing that they had that worked well was the hospice. But both those families were fighting for all of the other services in their children's last weeks. And these weren't terminally ill children, they were palliative care children. Neither of these families expected their child to die, but they spent their last weeks of their child's life fighting for other services. Yeah. So when it's not done on a departmental basis, when it's not done for right across the board for the region, then the inconsistencies and rightly so, the Northern Trust is focusing on that palliative care and the ability to look after people at the end of their life or with the complex needs. But it means they have to sacrifice something else. So they then become totally almost reliant on yourselves for what they can provide, and those families are not getting other services. So there's a bigger picture here where families are losing out, and it's unacceptable. The way we are sitting at this minute in time, and without the hospice, if they had to fight for the other services, which likely they may have anyway, they would have had nothing.
This is why we have social workers in the children's hospice, because we see very distressed families arriving all the time. I'm aware of yours, and Dan, you've had some as well. But those social workers are worth their weight in gold in terms of how they take that distressed family and help them navigate an incredibly complex situation. And more than once I have heard families have come to me and said, until we got to children's hospice, it wasn't just the clinical care, you took all the pain away.
I suppose that's something I think we need to raise with the department, is if they're not funding the hospice and it's becoming more and more difficult to deliver those services, and that's the only service that some families have, then, and they're already, the department is using that in order to shore up what they can't provide themselves at a, let's be honest, at a much reduced cost than if they had to provide it themselves. So I think that's a question that we need to be putting to the department as a committee, rather than an individual, because we constantly get this pushback on more money, more money, more money. Everything we have said, everything you have said here today, every answer we've got to the questions that you've asked, even through Deanne's questioning and how the department are currently spending money, tells us that money is being spent in the wrong way. That is money that we would have in the system to do things better. Everything can't be about more money, and we already knew that anyway. We've had enough reports on it, but we need to stop accepting not enough money as the answer to everything. It has to be about how we invest what we have and how the minister and the department invest what they have. But I absolutely cannot believe, just to finish on this point, that in the whole of the health department it has taken them 6 to 12 months to come up with a job description for the Chief Constable, who is responsible for the entire police service. And we had to review, obviously, the job description whenever that went out to tender, and we had to get an entire board to agree that description, and it didn't take anything like that. That is just ridiculous, and we need an answer to that question. Chair, what we want an explanation for that. That does not seem sensible to me in any way, shape or fashion.
Okay. Orlia.
Thank you. I'll just make all of my points together, Chair, because I know we're short on time now. So the first issue was just going back to the neighbourhood model, and I know from meeting with you previously we had a discussion around this, and in the Minister's response to the inquiry, it's referred to multiple times. In fact, the whole tone of his response to the inquiry was around this shift to the neighbourhood model, and language is used around this will include palliative care services. Improved palliative care services will be one of the key priority areas for our new approach. And there was more terminology around, this new approach will enable how we now look at, our improved palliative care services. There's one short paragraph then around, as part of the neighbourhood model, the department is working with Macmillan to develop a new approach to provide end-of-life care. So my first question is this: what input, what influence, what involvement do you currently have in the integrated neighbourhood partnerships where these decisions are being made, are being debated and are being discussed? Because if there's no active involvement in those localised groups at present, then I would question why the whole thrust of the Minister's response was around we're going to make these improvements via the neighbourhood model. That's the first point. The second point was around the legislation. So again, the Minister was saying that the department will give consideration to the need to introduce legislation to mandate the commissioning of the palliative and end-of-life care. But that would obviously come after the development of the new strategy. We've just discussed how long that's potentially going to take without the data. they then use the example of this, the Health and Social Care Reform Act 2009, where they're saying that should already give protection, that key health services should be commissioned. And I'm just wondering, is there anything that we could potentially work with in terms of that current legislation to ensure the commissioning of palliative care? And again, I'm not sure, does that open it up then to, you know, if you try and amend that legislation to include palliative care, does that make it difficult then for every other health service or part of the health service that's not commissioned? But just your views on that quickly. And then the final question is a very short one. It was just Diane's question around that, the scoping exercise, and I think, Trevor, you had mentioned, so the work that was underway in that working group, then the department are now accepting that they can't develop or complete that scoping exercise because the data is not there. And did you say that the department are now doing a report to confirm that?
Yeah, so
because I wrote that down and I wasn't sure if I heard that correct,
what
because
we've
it just
asked
sounds
them
bizarre.
to do as part of the project team is to be crystal clear in terms of draw a line now, confirm what can be done and what can't be done, and do you have a way forward or not? And that is the key clear ask that we have made, because there's no point flogging a dead horse. It's that simple. So we await what that may look like. And I do think that here's the positive in it. At least when you look at that risk register, there's an admission that it hasn't gone anywhere and isn't likely to go anywhere in its current form. So that is at least confirmation that there's an honesty and an integrity, that we are where we are and we're going to have to do something different. So take that as a positive, but we await what that looks like.
Timeline for that report, Trevor?
Don't have one yet, but Liz is the co-chair. Liz Cuddy is the co-chair and has had multiple meetings with the department to try and push that on. If we go back to your first point about the INTs, Danny asked the question as to whether or not we had been invited to those INT meetings, and we haven't at that stage, but we are now. So in terms of those workshops, we do have representation at those to try and understand that. We don't have clarity from those yet, but that is working through, and Max is probably better placed to answer the question in terms of the legislation. But what I will say on that is legislation is always a really long burn, trying to get it through, and it's complex to make sure it hits the need that you're describing, which is ensuring palliative care as a right, as opposed to something that relies on charitable funding.
And just quickly on those IMPs then, because you are sitting on those now, and I'm glad to hear that. So I would almost be using the Minister's words in those local groups. If there's terms of reference or whatever, it's in black and white there that this is a key priority for neighbourhood model. So use that to your advantage in those groups. Yeah,
and neighbourhood model is the panacea to almost everything, but that's probably because it is the right thing to do, but it needs to be done in a structure that leads to an outcome. And one of the things I'm always fascinated by is Danny did a calculation, and he was right within 100th of a percentage point, which is that in order to invest in palliative care, what we need, it's literally 0.002% of the health budget to be able to do this. But the improvement that you could make as a result of that is really quite remarkable.
Thank you.
Just in relation to legislation, we invested a huge amount of years changing legislation in Westminster. It hasn't had the impact that we thought. You could invest a lot of time in changing the legislation, and I think change comes if there has been a change, and I've detected an increased warmth from the department. It's come through relationships, it's come through your pressure, it's come through recognition that the finances changed, and there is an opportunity actually here for synergy between a neighbourhood model, between palliative care, between the queues outside accident and emergency departments, the pressures in the system. Even the department can't keep doing or supporting what we've always done because it's just not working. Would you bet that there's not going to be ambulances outside the Royal this Christmas or the following Christmas or the following Christmas? We've got to do something different. Palliative care, our neighbourhood model, helping, supporting the neighbourhood model vision. We've got a lot to give, to share in building those networks. And I just hope that we could be given that opportunity of working in that framework. But it needs to be done in a realistic way, not into 17 different little silos that is going. People don't die in silos, they die in homes, which may be in one townland or another townland, one trust or another trust, but they all need the same thing. So in terms of your other issue about finance, by putting finance this into palliative, will we run the risk of obscuring other areas? We're actually not in the business of building a palliative care empire. We are in the business of trying to prove end-of-life care, be it for people with heart failure or people with learning disabilities or people who are from the gay community or people from the immigrant community. It's about improving palliative end-of-life care for all. So if that isn't being delivered in those areas, then it needs to be. And if we can help in that, great. But better that they learn to do it. If you get... It's not about creating a hyper-specialist service which is doled out in tiny increments. We need a cultural change where we take on board seriously the needs of those at the end of life.
Thanks, really, Danny.
Thank you, Chair. A few of the questions I was going to ask have already been answered. But so thank you for your presentations, and particularly the poem. That was really powerful, and it gets across absolutely the importance of why we need to do this. I would reiterate the Chair's commitment to this. The committee has had a focus on this for a long time, and we are absolutely committed, and this will not be dropped for the remainder of this mandate. And as the Chair said, it will go into the report for the next committee to pick up. And I think with the amount of work done on the report and the strength of the recommendations, it is something that we'll carry. A couple of questions. The neighbourhood model and the INTs, there's 17 of them, geographically split around GP Federation footprints. So right across Northern Ireland, all of Northern Ireland will be covered. There's been 2 workshops already, and I think you've missed...
We missed the first one, but we were at the second one.
You were at the second one.
Thanks to the committee.
There's a third one coming up soon, I believe.
There is, yeah.
And you're invited to
Yes.
that. Very glad to hear that. Absolutely, you should have been invited to the first one, so I don't know why you weren't invited to that. So I'm glad to hear that that's happening. The moral case and the economic case really well laid out today. Absolutely, we know why we should be doing this, but there will be savings. It's better for the health service to be doing this. Second question, just with regards to the scoping exercise that is now not happening. We think we're waiting on a report to tell us why it's not happening. Waiting on the report to
tell us what the next steps are, if any.
Okay. What would it have told us? Would it have told us anything fundamentally new that wasn't in our inquiry report?
What it aimed to do was to clearly define what services were available for what kinds of patients and the throughput of those. The problem that they face is there's a myriad of systems, a myriad of different processes across a myriad of different organisations. So it really was almost mission impossible in terms of getting something clear out of that. So there's only 2 ways you fix that. One, you put something in place now which measures the minimum data set that you want going forward, but that would be a very protracted process, but would still be the right thing to do. Or the other is look at other proxy measures that would define potentially the kind of information that you need now in different ways. So that may be the way it goes, but we'll need to wait and see, Danny.
I thought our report gave us a really good breadth of what was happening in palliative care right across Northern Ireland, what the need was, what was being delivered already.
This is Max's point, and Claire's point, which is that there is information out there. Yeah. It just needs to be put together in a way that can be used to define what we need to do going forward.
And it's okay to listen to other places. We don't have to do everything ourselves or base everything on our own experience or our own evidence. There is really good evidence out there. If we wait for perfect evidence, we will be waiting for a very long time. We have good enough evidence now to move forward in improving our service.
Sounds good. And the department hopefully will be taking that on. 2 last quick questions. Just with the independent review of the comparator, are you being engaged with about that?
Yeah, that's a minimum requirement. So the whole point of this is there's no point in doing that away from us because we can't sign up to it, and that's why we are where we are. A benchmark came out of nowhere that no hospice signed up to, and we were paid on that basis, so no one ever agreed to it. That can never happen again.
Good. I'm very glad to hear that.
Yeah.
Can I just come to David on the neighbourhood model? Because it doesn't really fit for what you are doing as a specialist end-of-life care service for children.
Yeah, well, to be honest with you, I have very little knowledge of how it's going to work, and I need to get up to speed on that. So I certainly haven't had a detailed look at that and seen. But yeah.
There's details coming for all of us, and certainly we've heard it as an idea, but I think nobody's very clear as to how it actually is going to function. Sorry, just with, and then the last question, just looking ahead, what specific indicators should we be looking for as a committee about progressing the recommendations? What do we need to look out for, and what should we be asking for?
Depending on which recommendation you're looking at, but the first one I would go to is recommendation 3, which is what is the funding structure at the minute to maintain the services as they are at this point in time, and what progress has been made. And predicated upon that is the benchmark.
No problem. Thank you. Thank you very much.
Thanks. Nuala, you have time for one question.
I only have one question. Well, I have more, but given I was late and didn't hear the presentation that could have been asked. I had a visit to the Northern Ireland Hospice and Children's Hospice a few weeks ago, met yourself, Claire, and it was great to see all the work that goes on there. But I do have one question specifically around the finances, and it's good that some of the gap has been plugged for now. But why, if you don't mind me asking, it seems that Northern Ireland Children's Hospice weren't able to provide any additional respite, and there was money that was committed for respite, 13.1 million. Do you know why? I've asked questions to the department as to why the Children's Hospice weren't able to actually offer the respite, and whether that's something that you reached out to the department to actually do, and if you would have been able to, because we keep being told there's no places, there's nothing available, and it isn't just for families who have children who have autism and learning difficulties, it's for families who have children with complex need, like the Children's Hospice offer.
So the 13.1 million didn't arrive as far as the Northern Ireland Children's Hospice. What we did get was some slippage money, as it was described, for paid bed nights in the Children's Hospice, but it was at a rate way below the cost of providing the service. Now, we tried to provide as much as we potentially could for that, but there was nothing that would stand up a service.
Sorry, they didn't give you enough to actually cover what it costs, despite having 13.1 million.
We weren't included as part of that.
And the department has come back and they've said that there is money left over. Have they since gone back and asked? Have you?
We've been back multiple times. We have a business case in with the department now, asking to open a 7th bed. It has been moving along through the process, but we have no outcome from
it's
that.
Really
whatsoever.
interesting. They're almost trying to undercut you, or
Well, the trusts give us money separately out of slippage money that they have, and they say, can you provide beds for that? And we try to provide as much as families need it, but it essentially just creates a bigger hole in the deficit. So it's a moral dilemma.
Yeah, that's really difficult to hear, because they have come back to say that they weren't able to spend all of the 13.1 million, but we have someone sitting here saying they would have been able to offer respite beds.
We're aware of that, and we have challenged them on that also, but nothing.
And I think that we as a committee will now have to challenge them on that too.
And that is recurrent, 13 million as well, so that could have absolutely met the need.
Yep. Thank you.
And on your last point, we won't have to wait too long, because the department are in next week to talk about respite services. So we could talk all day about this, but unfortunately as a committee we have other business. So I just want to apologise to the members who didn't get in, but I want to thank you for that, and it's not the last time we'll be discussing it. Okay, thank you.
Could we give you details of what we've been talking about today?
Absolutely.
Please.
You just leave them at the back, we'll get them handed out. Okay, members, we're going to move to the item number 10 on the agenda, which is the oral briefing from Cancer Research UK on waiting times here in the north. Can I refer members to page 176 of the main pack? And just that we have representatives from Cancer Research here to brief the committee on the two reports, which provide an overview of cancer here and provide detail on waiting times for cancer diagnosis and treatment.
I come in there. Sorry, have we moved on to the next item? Oh.
You come back after.
Okay.
So our witnesses out there, are we? Okay, so you are very welcome. We have Mr. Nasser Tarabi, Director of Health Policy and Evidence within Cancer Research UK, and Ms. Liz Morrison, Public Affairs Manager here in the North with Cancer Research UK. So you're both very welcome. We've got your presentation, we've got the report, obviously, which is the important thing. So I'm going to hand over to yourselves just for opening remarks, and then we'll go to committee members' questions.
Thank you, Chair. I think most people here know me, but I just wanted to recap the work of Cancer Research UK in Northern Ireland. Cancer Research UK is the world's biggest non-government funder of cancer research. We invest about £400 million a year to support life-saving discoveries. And in Northern Ireland, over the past decade, we've invested about £20 million in research, supporting both scientific discovery and clinical trials that directly benefit patients. We help to ensure that patients in Northern Ireland can take part in clinical trials UK-wide and indeed sometimes internationally. And to directly benefit them. We also co-fund with the Public Health Agency the Experimental Cancers Medicine Centre in Belfast. But we work across the whole cancer system, from research and policy to health systems, and public awareness also to improve outcomes at every stage of the cancer journey. And of course, we work with you here at Stormont. So we're not just a research funder, we're a practical partner working across the whole system to improve cancer outcomes in Northern Ireland. I want to introduce you to Nasser Tarabi, who is our Director of Health Policy and Evidence and has been working very closely driving our work on cancer waiting times. And he's just going to set out the scale of the challenge here in Northern Ireland.
Thanks, Liz. So yes, my name's Nasser Tarabi, Director of Health Policy and Evidence. So I'm responsible for all our internal evidence generation, our data analysis, and our influencing on policy to improve cancer outcomes, policy and practice. So just to take a step back a bit. So cancer, you'll have heard the stat that almost 1 in 2 people will get cancer in their lifetime. That's a stat that we produced, and it's in peer-reviewed journal. We also know that cancer is a growing issue. So cancer is predominantly a disease of older age, although younger people do get cancer. And with an ageing population, we're expecting the incidence of cancer to rise. So it's about 10,000 people a year in Northern Ireland get cancer. That's going to rise to about 15,000 in 2040. So everything we talk about today needs to be seen in the context, not just of the challenges that we have today, but getting ready, having a system ready for the challenges coming. Inequalities, like all of health, feature heavily in cancer, so you're much more likely to die of cancer if you're from a lower socioeconomic group than if you're from a higher socioeconomic group. That's unfortunately something that's common to healthcare all around the world, but it also gives a focus for action too. I think we've got a specific issue, an exceptionally difficult issue in Northern Ireland to do with cancer waiting times, which I'm sure we'll talk quite extensively about today. But overall, I did want to just set out what we think are the key priorities at a very high level for cancer in Northern Ireland. So first is that cancer waiting times problem, and we'll talk more about what we mean by real focus on stabilisation of the problem and then through into recovery. That you have a cancer strategy already, and that needs delivering. And so it's not just about what happens in the hospital, but what happens before and indeed after the hospital. So making sure we have earlier diagnosis, which is the single biggest opportunity to improve survival, is to improve earlier diagnosis. So things like primary care, screening, public awareness. Preventing cancer is important. It should be said that's a long-term game. So, for example, we're still seeing a rise in skin cancer cases from sun exposure in the 80s, because often there's a 20, 30, 40-year time lag between exposure to the risk factors and actually getting cancer. But that doesn't mean that we shouldn't be taking action. And you'll know, obviously, that we've recently had the Tobacco and Vapes Bill, which is a great move for tobacco cessation. But we also need to invest in making cessation services and make sure we work on the other risk factors like obesity, like alcohol. And then cancer research. So the big improvements to cancer outcomes have come through breakthroughs in research. So we've had huge improvement in survival over the last 50 years, which has come from new treatments that have been delivered through research. And Northern Ireland punches above its weight for its population in that respect, and that needs to be maintained. I just wanted to end my opening remarks by saying, I've not just come to Belfast this time to come here, but also took the opportunity to attend a Cancer Strategic Advisory Forum that's run for health system stakeholders and some of the charity stakeholders too. And I must say I was actually encouraged yesterday to see the acceptance of some of the findings and a really thoughtful response to some of the recommendations in our No Time to Wait report that we published in January about the Cancer Waits Challenge. That doesn't mean that problem's sorted, far from it, but at least I saw a recognition of the challenge and a recognition of what needs to change in order to do that. So I thought I'd end on that somewhat positive note in my opening remarks before I opened up questions, because I know I've been to this building a few times and often come with some very negative messages. But yeah, I'm open to questions.
Thank you both. You mentioned the cancer strategy, and I just thought when you said it, I've come from a couple of meetings and engagements today, and we have some really good strategies, and if really good strategies determine patient outcomes, we would have an excellent health service. Unfortunately, that isn't the case. Your report does set out a stark picture. The North has the worst cancer waiting times in these islands, and that's a performance that's getting worse over a period of time. So you raise serious concerns that delays are now leading to harm, including limiting treatment options for patients here in the North, and you also outline how serious you believe the current situation and the implications that have for patients. So that's very severe in terms of the work that this committee does, scrutinising the work of the department. In particular, you've highlighted that delays may result in patients becoming too unwell for treatment or losing the opportunity actually for curative options. So in your assessment, are the current waiting times that we have for cancer here in the North now at a level where they're likely to be actually affecting patient outcomes and survival?
So this subject's actually quite a hard thing to have really solid evidence on, because it's an unethical thing to do a trial on. You can't give some patients treatment at one time and then delay some others. But the best estimates that we have from modelling are that for certain cancers, so this particular study looked at cancer surgery, that for every 4-week delay for certain cancers, there was a 6 to 8% increase in mortality and rates of death. Given that the waits are so long, down around the 30% mark of patients treated within 62 days, long median waits, there's some of the details in here, so we're well into that territory, certainly. So I can't tell you who has suffered, but I think it's an accepted fact that people will be suffering harm because of these delays.
Okay, so we can't prove it, but we know what's happening. Yeah, okay. Your report also makes clear that increasing demand alone, so people are living older, there's more incidence of cancer, so there is an increase in demand. I think we have to say that, but it doesn't explain the decline in performance, because that's the same situation elsewhere across these islands. So in terms of what is specific to the North, what we're not doing that other areas are doing, what we need to do, or Can you just outline the key factors of why we are performing here in the north so significantly bad in comparison?
So this starts to get, these are our judgments, these are my judgments based on talking to people in the system. Again, you know, it's a complicated topic. So a few things, you know, when I compare Northern Ireland with similar size health systems across the UK, so obviously CR UK, we work across all 4 nations, and I see a lot more capacity to deliver improvement, so not just clinical capacity, but the capacity to deliver the transformation that's needed to keep up with the rise in demand. I can see in tangible ways, for example, pathology services, pathology waits in Northern Ireland. So pathology is what delivers the laboratory diagnostics. It's completely essential for not just diagnosing, but planning the treatment and planning personalised treatment for patients. Pathology waits are shouldn't be measured in the weeks on a cancer pathway, but they can take several weeks. One of the challenges that all services have to deal with, but clearly haven't kept up with demand here in Northern Ireland, is it's not just the ageing population, but new technologies. So lung cancer, thankfully, 15 years ago, there were about 3 different treatment strategies for lung cancer. Now it's more like 25, 30, which is brilliant. That's what's leading to improvements in lung cancer outcomes. But actually, that means extra steps in the pathway. So genomics, for example, no one was talking about genomics 15 years ago, but now many, many cancer patients, not just in lung, need to go off for complicated high-tech tests to be able to personalise the treatment for their cancer. You know, I'm told that Northern Ireland was ahead of the game originally on genomics, but I think over the last 5 to 10 years has just not kept pace with the transformation that's required to deliver that. What I do see, and you know, since I last came here, I've done some more direct comparisons with similar sized systems. And indeed, my old job before I worked for Cancer Research UK was working in a health system about size in terms of population of Northern Ireland. I had a team of about 25 people working on cancer transformation and system leadership. So not inside the hospitals, but doing projects to bring in new innovations, support data, extracting the data that helps people manage the system. And that's something that doesn't exist in those numbers in Northern Ireland. So somewhere along the line, the investment in the management capacity to support the clinicians to get the most out of the system has fallen behind. I think I couldn't come to a meeting like this without mentioning Epic. That's not to say that Epic is an excuse, because I work with a lot of sites in the UK, across the UK, that have implemented Epic. Everyone has difficulties all over the world, whether in the US, Australia, wherever, implementing a system like that. I think every Epic implementation, you need about 2 years to stabilise things, and then you need another few years to realise the benefits of it. So the way that's happened in a sort of staggered way, effectively you're 9 months since the last go live in Northern Ireland. And that is a very disruptive thing. And what I've seen is that the investment in building out the Epic and the cancer processes that are needed has not kept up with what's needed. And so that's going slowly. So although I think ultimately Epic will be of huge benefit to the health system, or an integrated IT system will be of huge benefit, that's a very disruptive factor. So I see all these things along the way. I think the degradation of the management capacity, NICAN, you know, I used to lead the equivalent of NICAN in another part of the UK, and it's half a dozen people compared to the 25 that I had. And that affects clinicians because they don't have time to improve the work that they're doing. They don't have time to make sure the variation is reduced. I think the budgetary situation, I'm not necessarily saying the amount of budget, but the budgetary situation here, the inability to plan long term is a real challenge. we talk about invest to save. So you're putting in a new piece of kit that will take 5 years to return on that investment with patient benefit, but also financial benefit. So, for example, there are things that you can do to implement new technologies on the bowel cancer pathway to reduce the number of people who go on to need a colonoscopy. It takes an upfront investment, and what I'm hearing is that those business cases are hard to get through. So there's a number of things that seem to have seized up in the healthcare system within Northern Ireland. I think what we're also seeing, and from talking to people, is that we're in a bit of a vicious cycle of I guess, incentivisation and expectation. So the 95% standard is a long way off in Northern Ireland. And I see this, with my background as a manager, as a change management challenge, And in a change management situation like this, where you've got lots of hardworking staff, I think they're feeling demoralised by the challenge that's ahead of them. And part of the, when we talk about stabilisation and recovery plan, a really important part of that, I would say, is breaking down the steps that are needed into manageable steps. I used the analogy this morning talking to someone of, I wouldn't tell my 13-year-old daughter that her objective is getting a first at university. I'd say her objective is to do her homework tonight. And we really need to break down this problem so that we can support staff to deliver their best.
So you're just moving on to my next question, actually. So your report, you're calling for like a crisis response over a time-limited stabilisation plan and a time-limited stabilisation plan to address the waits and reduce harm. So, the function of this committee isn't just to call witnesses to hear problems. We actually want to hear solutions and be able to advise the minister. So we have prioritised waiting lists, and within waiting lists we've prioritised red flag cancer. So we want to be able to assist the department in trying to deal with this problem. So for our purpose as a committee, what would look good if we were back talking to you in a year's time? Like, what specific actions do you think need to be taken, and what outcomes would we like to see or expect to see if we're able to take those actions?
First, I'd say that there's some good signs, as I mentioned earlier, to build on. So I think you'll have met Damien Mackay, who's the clinical director of NICAN, and I think he's been supported with an operational leader, cancer programme director alongside him, who has direct experience of working in hospitals and working in cancer services. That's a really good sign. And what I've heard from them, I think, accepts the scale of the challenge. So that's a good start. And I think a big part of it is just making sure those clinical and operational leaders who know what they're talking about are supported. I think part of the way of supporting them is somehow getting that management capacity to get things done. I see we're not short of ideas. Damien and colleagues can list 100 projects. I mentioned a couple, talked about sorting out genomic waiting times, sorting out the EPIC build for cancer pathways. Those are just two examples that of many I could give, and Damien could give the full list of projects that need delivering. But when you've got a clinician who's got clinics to see, it's very hard for them to free time to deliver it, and we need to, and for every £1 million that's invested in clinical capacity, I'd be looking as a rule of thumb as 10% invested to actually realise that benefit, realise the benefits of that, because you can't keep doing the same thing. So anything that we can do to provide that support to this transformation that's needed is really, really important. And I mentioned budgets that enable some of that slightly longer term planning. So those things I'd focus on, that transformation capacity. Some of the other things that exist, like that, I think there is reasonable work on, but it's a bit longer term horizon. So, getting training places for the right number of doctors and other clinicians that we need. That's obviously the right thing to do, but it's also not going to deliver for a while. And the other thing I would say is to seriously consider these incremental targets. I'm not saying that we should, certainly as a cancer charity, support the ambition that we have to achieve 95% of patients being treated within 62 days. But we need to turn that into a set of incremental targets. So, for example, I'd be focusing on the areas where there's highest clinical risk. For example, gynae keeps coming up, haematology keeps coming up. These are often rapidly progressing cancers with particularly poor waiting times. That's certainly not a comprehensive list. Focusing on particular trusts with particular issues and making sure the support is there for them. And I think focusing on those priorities that are proposed by the people who know what they're talking about, rather than the top level standards.
Okay, thank you. That has been helpful. I mean, there's a lot of other areas where I could get into. Early detection, you mentioned, we're so behind the curve in terms of that here. Others will pick up on that, I'm sure. Clinical trials, I'm sure people will pick up on that. But I'm just going to start going around the room now. Colin?
Oh, thank you very much, Chair. Look, thank you for the presentation. And I mean, the figures that are contained in there should scare literally the life out of us. The length of time that people are waiting. And any time that I'm talking to a group that asks about health services, and I always recount how if you go to a GP and the GP was saying to you that they think or suspect that you might have cancer, you would be literally saying, well, is it today or tomorrow that I go to get the next test? And yet quite often here we can be waiting months before you get to go for those tests, and that is just frightening how it's treated by such a lack of urgency. And I do worry about how here we may have desensitized ourselves to the fact that anything more than about 24 to 48 hours, maybe 3 days of a wait is just not acceptable, but we've got such a massive wait here. Are we in a sphere where we have just desensitized ourselves to thinking 6 weeks, 8 weeks, 10 weeks is acceptable? That's just what the norm is. And what is that like in comparison to other parts of the UK and Ireland in terms of, is there things that are happening there that are taken as norm that just don't happen here that we should be seeing?
So I think my answer a year ago would have been different to my answer today. And, I remember some of the faces from a year ago when I came. I've seen a real acceptance, and I think in response to this report, of some of the urgency. I think just break this down. So first of all, in terms of the desensitisation from the public, a really dangerous thing to happen is for people not to present to their GP or to health services more, or to go to screening because they're worried about the waits. Much better to be on a waiting list, however long, than sitting at home. And broadly speaking, the wait that we worry about the most is that wait at home where someone's someone's sitting, not doing what they should do about symptoms, about something not feeling right about their body. So whatever we do, we should avoid that effect. In terms of the people within the health service, I would say, if you're a clinician who is dealing with overrunning clinics, possibly quite distressed people because they've waited an exceptionally long period of time, that is a demoralising situation. And when there are budgetary cuts, there are cost savings to be made, cost-saving targets every year, that's an incredibly demoralising situation. And that's something I'm familiar with in my own career, from working in hospitals at certain times. I think the crucial thing here is to make sure that we have, and this is why we're calling for it, a plan that sets out the critical steps to recovery. I think there are the framework for a good plan in place, the elective care framework, but it's not what the detail that I would like that would reassure a clinician and reassure a health system manager that there is a set of interventions that will get them where they need to get to. And that's why I think, you know, part of the contribution that you can make is actually giving permission for that incremental approach, because keep focusing on, to use my analogy before, on your degree result when there's homework due tonight is I think is causing a level of disaffection or difficulty of people to engage with the challenge. But having said that, I've not seen any evidence of clinicians who are anything but working to support their patients. And it's one of the assets that Northern Ireland has, is well-trained, effective clinicians and other staff. But we can do more, and so, you know, there's a list of priorities that will change this attitude. There's a list of projects that, if people had confidence, were going to be delivered, that will change this attitude.
I suppose it's a really important point that you make, that we don't fall into that territory of that the health service is so difficult to navigate and can take a little bit of time to get through, that people throw the hands up and go, well, sure, I'll not worry about that symptom, because by the time you get an appointment and get sorted out, it'll be next week. And that really people need to listen to their own bodies. If their body is telling them something, that something's not right, then they need to get to a doctor. And if that takes 2 or 3 days, that's terrible. But keep trying, get in and get into the system, because once the system picks you up, it will try to sort you out. It can just take a bit of time to navigate it. We need to work on that, but we'll get there, hopefully. I suppose then, given that you've said that it's a series of small little hurdles rather than the big, massive issues, but I mean, if you're back next year, what one thing would you like to see us do? What's the one thing that kind of unlocks the rest of them? Is it a combined effort? Is it a combined mindset? Is it finance? Is it personnel? Is it what's the one thing that unlocks the other? Or maybe there isn't one thing that unlocks all of it.
Well, answer it in sort of 2 categories. So I could give you the list of, call them interventions, that will change things. I can give you a few examples of that. I mentioned, you know, the EPIC issue needs to have been sorted in 12 months. Those cancer pathways. But I know I've worked on EPIC installations myself in my last job in the National Health Service, and there'll be a queue of things in there, and a lot of the things that we're talking about are not direct patient care, so you know, they need to prioritise accordingly. But 12 months, I think there's no excuse for those for the processes not to be in place in the IT system. You know, I've mentioned things like pathology turnaround times, that kind of thing. Absolutely room for improvement. And a kind of higher level, thinking about, you know, the conditions, I would love to see an environment where people can be submitting business cases that deliver over the course of multiple years, because this is a complex environment. Practically nothing will deliver in a year. You know, it takes that long to implement a new bit of kit or recruit some staff and get them bedded in and trained. All of those things take time. And we talk about pilotitis. You know, it's very easy to drop some money in over a year and then expect it to sort of magically lead to sustainable improvements. But I think that long-term focus, to have seen a few business cases get through because they will deliver, and I can give you an example of a few. So something like colon capsule endoscopy, which is this, you know, you can swallow this capsule, takes a video, and then that video gets transmitted. That should be in place in Northern Ireland, but it's not. In fact, it should be in place in Northern Ireland more than anywhere else, because your queues are so long. The case for doing it is much stronger. You're not a borderline case here, which is why it's not in place in other places. So, you know, there's a list of things like that, and it's not just technology. It might be investing in prehab nurses that improve the outcome of the treatment and reduce the bed days. that people are needed, which has a direct impact on cost. These are all examples of things where you need small upfront investments, and that's where these sort of short timelines don't work. You couldn't run any capital intensive business on an annual budget.
Fair enough. Yep. Thank you, Chair. Thank you.
Yeah.
Chair, and thank you, and it's good to see you again. Your report says that no trust in Northern Ireland is currently meeting the 62-day or the 31-day standards for any cancer site. And that's very sobering, because the longer we wait, the more dangerous the issue becomes. And I would have to say the more terrifying for those people who are waiting. So I think that we do have a very big problem. I have asked the Minister over and over again about an emergency plan to stabilise cancer waiting lists. And the answer is always, but sure, we have the elective care framework. So, and we have the cancer strategy. But of course, only a fraction of the cancer strategy is currently funded or even remotely implemented. So what's the difference between your idea of an emergency plan to stabilise cancer waiting lists and the elective care framework and the strategy? Just to, let's simplify it all out. And because I don't think we can go on as we are, because I think that's morally indefensible. But let's get the three things.
So I think the elective care framework is fine for what it is, but as far as we're concerned, it doesn't go deep enough. So I'll tell you the ways. So one is that the detail of the actual interventions that will make things better are not in there enough for cancer. So it's impossible to encapsulate the detail that's required of the things that so I mentioned things like colon capsule endoscopy. That's just one pathway. I could create a plan just for bowel cancer that's the length of the elective care framework, and so it doesn't list the critical steps that are required that will get you from where you are now to where you want to be in the detail in enough detail. I think the other thing is that the focus is very much on the resources and inputs. So we will create this many more, we will employ this many more clinicians, insert this much more money, but there's not enough on what they do with that money and exactly where that money is going. And some of these things might be, they might not be the big public facing plan, but at the moment, I don't think there are the detailed plans in place, at the level, at any level really, apart from maybe within the trust.
Is that true for the elective care framework generally, and then doubly true for cancer?
Well, I wouldn't comment. I think I probably wouldn't comment on the non-cancer aspects of that, but the detail that I would like to see for cancer certainly isn't there. Cancer's particularly complicated, I would say. So, you perhaps wouldn't need that same level of detail as you would. But I think also the other thing I would say, first aspect is the list of interventions that add up to where you want to get to. So it'd be saying things like, colon capsule will reduce our demand for colonoscopy by 10%, and therefore that will lead to a reduction in waiting times by X. Those are the words that I would want to see in a plan. And then, but it doesn't have that level of detail across the board, across every single pathway. So whatever that 15, 20 different pathways, depending on how you cut it. The second thing I'd want to see is who's doing the work. So, if I'm writing a plan, if I'm writing a project document, I'd be saying, well, how are we going to deliver each of those things? Not just we're going to put it in, but it's going to be delivered by X. It's going to have a responsible officer named here, and that person will be held accountable at these forums. That's what I would see in a plan. The other aspect to this is some of that, what I was talking about before, which is feasible, realistic targets that are related to the intervention. So, and then what I mean by realistic is that you are not going to get to 95% anytime soon. And England, and who've been throwing hundreds of millions of pounds at the problem, are still down at 70%. I'm not suggesting that there's an easy route to 95%. But I would be saying, well, actually, if you add up this list of 10 high priority interventions that we've implemented, that we're planning to implement, this is what the expected impact will be. And that will get us to, X percent, say 45%. And that's what we're going to focus on for the next 18 months. And then we're going to review. But at the moment, you've got the standard over here, 95%. We're going to invest in some clinical capacity and not much else.
So what you're saying is a plan that's more specific with greater detail for cancer is necessary without the elective care framework.
Yeah.
Yeah.
I mean, so just to summarise, so the realistic targets, the interventions that add up to what you are going to get, the responsibilities and the resources, so these all need to line up. And then I think most importantly, I think, is something that is achievable, that faces clinicians, that gives them the confidence, not just yourselves, because actually the people need to deliver this, are the clinicians themselves, and it needs to have their confidence. And at the moment, the document that we have is a policy document.
So it's an action plan you want?
So it needs to exist, and absolutely how it's held to account, how it's assurance is provided is probably more your call, but I want to know that it exists.
And I'm sure loads of others are waiting to get in. Can I just ask one question about one of the things I read in the report was the extremely poor performance against rarer cancers. How do we tackle that issue? That is. I mean, it is very, very worrying that some of the, I suppose, lower GI cancers are very, 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 very poor results in those.
Yeah. So, I mean, rarer cancers is a problem worldwide, and we need to just make sure we separate what we can do. So, generally, in my work, I separate the things that we know how to do and the things that need more research, and rarer cancers are more on the need more research. We had a great result at the big American conference a few days ago, last week, where there was a doubling of survival time for pancreatic cancer, but it only doubled from 6 months to 12 months. These are tough cancers to treat. There are things that can be done in any system. So one of the things that I did, and I'm not suggesting these are the first things that you would do, so don't take this away that this is part of the emergency response, but my last job was in London, and I helped deliver a big reconfiguration exercise that finished in about 2018 that centralised, for example, all the prostate surgeries. That prostate cancer surgical centre at UCH now has the best outcomes in Europe, and there are big benefits to concentrating specialist expertise. It's a tough process. There are other things, though, that equally absolutely should be delivered wherever, and actually new technology is making that more feasible. So, for example, delivering chemotherapy by subcutaneous injection at home is feasible for some treatments. So it's just having, and this is where NICAN is very important, but it's currently under-supported, because what you need is a healthy clinical reference group for each of those rarer cancers that is working together to drive up standards. That's the practical thing that needs to happen. So until you've got a clinical reference group chair in place with a well-supported group, you're not going to make significant improvements for any cancer, frankly.
Thank you. Just a word. I actually, a few weeks ago, went to the Genomics Centre in Belfast City Hospital, it is phenomenal, the potential for this to be applied to cancer and to other illnesses, and potentially something that we as a committee, on the basis that every day should be a school day, it was a good thing to do, and it was hugely interesting. It really was.
They've contacted me, and so I've asked them to invite the committee as well. So I
fascinating
think,
thing.
It'd be worthwhile. Okay, thank you, Danny.
Thank you, Chair. Again, some of the questions I was going to ask have already been asked, but I think we're all thinking along the same way. So thank you very much for your presentation and the report. One thing that did jump out at me that's been highlighted in the latest waiting time stats, the urgent breast cancer referral times. I think we've actually dropped. Target obviously is 100 to be seen in 14 days. I think we've dropped from 6.8 to 5.5. So we're actually going the wrong way with urgent breast cancer referrals. Certainly, as a constituency office, I've had constituents come into me incredibly worried about the length of time they're waiting for this referral. Incredibly stressed. The impact that it has on women and their families is horrendous. Why are we going the wrong way?
So I think specifically in that circumstance is a good example of where, when we talk about stabilisation and recovery period, so I don't have access to the detailed data. So just give you that health warning to begin with. But in some cases, when you're clearing a backlog, things get worse before they get better. That's just an arithmetic thing, because the metrics measure the number of the patients who were treated or seen, whatever the metric was, that month. And if you've got a bunch of patients who've already been waiting beyond the target and clearing that backlog, arithmetically that number goes down. So I don't know if it's that in that specific circumstance, but that's the kind of thing that you guys need to be made aware of so that you can interpret the data correctly. The other thing I would say, and I need to say this very carefully, because at Cancer Research UK, our fundamental focus is survival and quality of life for the rest of your life as well, and that comes by getting access to the most effective treatment. And so the thing that I'm laser focused on is the 62-day target, actually. And if you had a plan that said, actually, and quantified it and said, we will focus on the 62-day target, that means that you might see this other target getting a bit worse, but by focusing on, especially on the high-risk patients as well, because there are certain breast cancers that need to be treated more urgently than others, then you would have the reassurance that the system was working well.
The 62 target, though, the 62-day target, the stats for that, it was 30.1% the previous quarter, and we've actually went down again to 29.5. So
and again, I don't know the exact numbers, but that could easily be clearing backlog. Because what I've also heard is that some of those early diagnostic weights, and this is welcome things that are happening, have been getting some support from a Scottish centre, people coming over and clearing those diagnostic backlogs. So that will also affect the 62-day target, because remember, some of those patients who've breached the 62-day target were waiting into even the hundreds, the triple-figure days already.
Even as you're doing them, it doesn't affect the number.
Yeah. So I mean, I would argue, once we have the data and look at it, there'll be some cases where the relevant target isn't 62-day, it's your backlog reduction. And that's it. So post-COVID, in England, they publicised their backlog reduction and said, right, for this 6-month period, we're focusing on reducing the number of long waiters. That was the right thing to do. This is the kind of thing that I was talking about in a crisis response, is that
incremental targets.
Yeah, incremental targets. In this situation, the right target isn't necessarily only the 62-day.
I wanted to ask you about, you're a member of the Non-Communicative Disease Alliance as well, and certainly minimum unit pricing was something that we were very much looking forward to the Minister bringing forward a bill on. The evidence seemed very, very robust. It's been implemented in other areas around the world. In terms of cancer, what impact would it have had on cancer diagnosis?
Well, About 7% of cancers, alcohol abuse is and use is the third biggest cause of cancer. We've seen, obviously, we're not going to see immediately the impact of minimum unit pricing because, as Nassar was saying, it can take 40 years for that cancer to develop. It doesn't develop overnight. But what we've seen in Scotland is very robust evidence that it does bring down cancer deaths. It does bring down the rate of alcohol abuse, and you see it in other alcohol-instigated illnesses. The NCD Alliance commissioned a very good piece of research from the Sheffield University that sets out in a lot of detail the Northern Ireland specific situation. I would love to remember all the numbers in that off the top of my head, but I don't. But it did give forecasts for how many fewer bed days for people with cancer there would be. And I think between that and what we've seen in Scotland, there is robust evidence. And I know there has been some contesting of the Scottish evaluation. We believe it's a very good evaluation overall. There was one particular fact that people quibbled over in the presentation in a press release. But we think that when you look at the international evidence from Scotland and from other places and the emerging evidence from Wales, there is a robust case for a cancer case for minimum unit pricing, as well as a health system-wide and indeed a justice system case as well. You know, it will save lives for people with cancer. It will save lives right across the health system, and it will save money.
And certainly it was seen as a big missed opportunity. Okay, one other question, just about late-stage diagnosis. Reducing late-stage diagnosis, obviously, very important. 6 out of 10, I think it's 55% of cancers are diagnosed in the early stage, but there's quite a variation in between the types. The one that struck me was 29% for lung cancers. We don't have a screening programme in Northern Ireland for lung cancers, but I believe in the rest of the UK there's established programmes that are rolling out. So we're quite far behind in that. What difference would that make in terms of treatment and in terms of that 29% number?
Yeah, so the early evidence from the English programme is that they've made huge improvements on early stage diagnosis. So, you know, I'm looking here that so in Northern Ireland we estimate about 210 patients each year would be diagnosed at an early stage rather than a late stage. So 60 lung cancer deaths avoided each year through the programme. And it should be said as well that once you've got over the hump of finding, you know, got that programme established, it's much cheaper to treat early stage lung cancer than it is to, you know, it's the difference between interventional bronchoscopy, which is a day case, and, you know, big open chest surgery with poor outcomes. So early diagnosis of cancer makes sense both because it's the right thing to do, but also it's financially beneficial. So yes, Northern Ireland is behind on that. And this is an example, I would say, of not being able to plan for the long term. So optimising screening, some of the investment that's required in that. So, for example, lowering the threshold for accessing bowel screening is something that we would support, and ultimately leads to early stage diagnosis and cheaper treatment. You know, it's much easier. You can treat bowel cancer in a colonoscopy as opposed to major surgery. And so for lung cancer in particular, you know, all the other nations have made commitments and are relatively far down the path. England's furthest of implementing lung screening. And it should be something that's done here. It's hard to diagnose lung cancer early any other way because the symptoms don't show up until it's already spread.
Could I just add on that lung cancer is our biggest killer? cancer killer in Northern Ireland. It takes about 1,000 lives a year. And those are not, it's not equally spread across the population. It's one of the biggest inequalities that we see. If you live in a deprived area, you are 45% more likely to die from lung cancer. And that is in Northern Ireland, and that's really unacceptable. It comes back to, as well, needing things like smoking cessation, things that will help down the line, but lung screening would have a really big effect on evening out some of the inequalities.
60 lives a year, wasn't it?
Yeah. If you fully implemented lung screening, when?
It really is phenomenal. And like alcohol, it is an area of deprivation where you have the higher risk factors. So
it's highly associated with smoking, which is associated with deprivation.
Okay, thank you, Chair.
Thank you, Danny. Linda?
Just one quick question, because you answered almost anything that I had. Do you include mesothelioma in the lung cancer deaths in those figures that you're quoting? Would that be included?
It would be included, yeah. I think it'd be a relatively small number, but absolutely, it would be.
Equally an inequality, because those who lived and worked in poorer conditions are more likely to have it.
Yeah.
Now, not right across the board. We know that there are some cases of staff in hospitals because there was asbestos in the buildings, and so they wouldn't necessarily be in the working class section, but still. I just wanted to check that. That's okay. Thank you, Chair. Thank you, both of you. Thank you very much.
Thanks very much, Liz Nasser. That has been very useful for us in terms of the work that we're doing. So we really appreciate you coming. That's been good evidence for us. Thank you.
Thank you very much.
Good evidence, but unfortunately, very
always keen to help wherever we can.
Thanks very much.
Thank you.
Okay, members, we're just going to kind of go into reverse now. So we're going to go back to Chair's business. So just very quickly update people, myself and Danny and committee staff and the Mike Farr, Permanent Secretary, were in London Tuesday night and yesterday. So we met with primary care leaders to learn more about the delivery model for primary care in England. And so just to let you know, from my point of view, it was a really informative meeting. We're going to get a note prepared on the visit, and it will be circulated to members, so we'll discuss it more when that's done, but it was very useful. Also today, mental health champion event in conjunction with us and the committee, myself and Danny were there as well. So took place this morning. Again, a note on the event will be prepared and circulated to members. I mean, there was stakeholders and members of the community and voluntary sector there to discuss how the mental health could be improved with the formation of the neighbourhood model. I was very surprised to know, particularly from the community and voluntary sector, some of them had never heard of the neighbourhood model or knew the detail of it. So I think from a departmental point of view, there's a bit of work there, just making sure that everybody is aware of that moving forward and how it can help and how people can participate and play their part in it. Because if we're talking about shifting left, then obviously the community and voluntary sector is crucial in that. So I want to thank the mental health champion and the permanent secretary, both who spoke at the event, and also for those stakeholders who attended and sharing their views and experience.
Okay. Can I apologise, and I'm sure others will as well, but can we just be so super careful with that first Thursday of the month, because 4 of us are at the policing board, and if it was one of the other Thursdays, there's only some of us involved in committees and stuff, but the first Thursday of the month in the morning, all 4 of us are probably expected to be there, because that would have been a lovely event to be at, and I know we were tied by probably people's availability rather than ours, but I think it would have been good to have been at that one, but
it's
just apologies because we just couldn't get.
And I did note the apologies of I did say about the clash with the policing board, so it's a fair point for us to note. Draft minutes, members. So draft minutes. Oh, sorry. Before we move to the draft minutes, there's a press release on the back of that event sitting in front of you. So if everybody's content that we issue that, happy with that? Okay, thank you. So draft minutes of the meeting held on the 28th of May. Are members content with the minutes? Thank you. Matters arising? None. Okay. Item number 5. Tobacco and Vapes 2026.
Chairman, could I just, I'm a registered tobacco and vapes retailer. Can I just declare an interest?
Good enough. Thank you for that. So we've got that SR. Advise members that the purpose of the SR is to provide a date for commencement of certain provisions from the Tobacco and Vapes Act 2026. Tobacco and Vapes Act was previously before the committee and the Assembly as an LCM in early 2025, and consent was provided. So this type of rule is not subject to any Assembly procedure and is therefore solely for us as the committee to note. We don't need to make any decision, or there's no further approval required. So I'm just asking if members note that SR. Okay, item number 6, the tobacco retailer miscellaneous amendment. Alan, I'm assuming your declaration.
Yes, just extend that to 5, 6 and 7.
Yep, okay. So the purpose of this proposed statutory rule is to make minor amendments to existing legislation to ensure the terminology is updated to reflect expanded range of tobacco, vape and nicotine products in line with the Tobacco and Vapes Act 2026. So the proposed statutory rule is subject to the negative resolution procedure. So I'm asking members today to note the SL1 information and papers will be published on the Assembly website along with a call for views. To also agree that the SL1 will be scheduled for consideration at the meeting on the 25th of June, and also if you are content to schedule a brief evidence session from officials on the SL1 prior to consideration on the 25th of June. Content with that?
Yep.
Okay, item number 7, tobacco retailer fixed penalty amount. Advise members that the purpose of this proposed statutory rule is to update fixed penalty offences and the amount of fines payable to align with changes brought in by the Tobacco and Vapes Act 2026. Unlike all other SL1s the committee have dealt with recently, which have been under the negative procedure, this proposed rule is a draft affirmative procedure. So the standard practice here for rules that deal with fines and financial matters means that the statutory rule, once made, will be subject to a debate in the plenary. Therefore, members may wish to invite officials to give further evidence to the committee on SL1, and the session and Hansard report could then allow a better understanding and inform members and the rest of the Assembly for the debate. So I'm going to ask that we note the SL1 information and papers will be published on the Assembly website, and also a call for views will be issued, and that we agree that the SL1 will be scheduled for consideration at the meeting on 25th of June, and that we're content to schedule a brief evidence session from officials on the SL1 prior to that consideration on 25th of June. I think that's all sensible. Everybody happy with that?
Yeah.
Thank you. Item number 8, new Firefighters pension scheme. So the committee noted this SL1 at its meeting on the 21st of May. Purpose of the proposed rule is to amend the existing new Firefighters pension NI 2007 to complete and improve the delivery of the Matthews remedy for retained part-time firefighters. So the SR will be subject to negative resolution procedure. So there's been no responses to our call for views on the proposed rule. So if members are content for the department to make the rule. Content? Okay. So 9 is done, 10 is done. 11. So we've a written briefing from the department on hospital car parking charges. So there's a written briefing at page 217 of the main pack. Any comments? So are we going to still get these written briefings during the duration of the legislation? That is there merit in putting a?
So, Chair, this was, we'd requested regular briefings every 8 weeks up until this period, the May 2026. With the new legislation in place, it'll be down to members to decide if they want regular updates or what they look like and how often they are.
I'm not sure we need 8-week briefings of a piece of legislation that's not going to be. Go ahead, Paul.
Sure, I think didn't I put down an amendment in the bill that went through asking for an annual update on the costs and various bits and pieces to do with it, and that was accepted in the House. So we'll get an annual update through it. So maybe that would negate the need for us to have up these ones. Would that?
I do think it would be useful at the time when the legislation is running out that we get an update, because obviously we're in a different scenario there.
One thing just with this is on the hospital car parking.
Yep.
So 200 N PR cameras have been installed across trust areas and are currently operational for data collection purposes, so not obviously how they were initially supposed to be used. What data is being collected, why is it being collected, and what's being done with it?
I imagine it's the volume of traffic, but we can ask for that. I'd say it's just they're collecting numbers of cars.
Interesting to see what, it was not the original purpose of the cameras, so.
Well, we should ask that. Okay, members, item number 12, correspondence. So correspondence in the main pack, page 222, and that includes the index at 223. So there's correspondence from the Professional Standards Authority for Health and Social Care at tab 12.10, page 319, regarding its most recent performance review of the Nursing and Midwifery Council. So the PSA reports that NMC has met 9 out of the 18 standards during 24-25. So that's only half, obviously, which isn't good. I would be suggesting that, given that we write to the NMC to just request regular updates on progress to meet the remaining standards, if members are content with that.
Yeah.
Okay, so also...
There's an interest there, Chair, just as a nurse registered to the NMC.
Okay, so there's also correspondence from Nick Ictu at tab 1213, and that's requesting that they informally brief the committee ahead of recess, so I would be happy enough to accept that request for an informal briefing if everybody's content.
Mm-hmm.
Yeah.
Okay, so there's a few other things. I mean, one thing that struck out at me just was the letter from the Minister in terms of our letter to him about the social care sector, where the independent sector had kind of withdrew engagement. Now, it's welcome that they're going to come back on board, but it just shows that, you know, they're up. I mean, we've highlighted this as individual MLAs in the Chamber and this committee ad infinitum. So, you know, again, I think the committee should encourage the department to kind of engage constructively with the independent care sector, because it is an issue that is obviously important for the independent care sector, but it's an important issue for all of us in our health service in totality and right across the board. So I do think that I welcome the fact that they're back on board and that there's constructive engagement. I hope that constructive engagement produces benefits on the living minimum wage, but also further things that are needed within the care sector and our health service. So I just wanted to point that out. Is there anything anybody else wants to point out in the correspondence tabs? Okay, so are members then content with the suggested actions in the correspondence index at page 223?
Yes.
Okay. Draft forward work programme at page 392. Is everybody content?
Mm-hmm. Yeah.
So departmental officials have confirmed they have requested the introduction of the data processing amendment bill, and it's been considered at the next executive meeting. Officials advise they hope to introduce the bill in the Assembly 22nd of June and second stage on the 30th of June. So committee staff will prepare a timetable for us, an agreement based on the bill reaching committee stage just before summer recess. Content with that?
Yes.
Okay, AOB.
Yep.
Good. Date, time, place of next meeting is room 29, Thursday the 11th of June, 2 p.m. Meeting adjourned.